Today we're going to be talking about the child with a life-threatening condition and end-of-life care. As always, make sure that at the end of the slideshow that you look back at these learning objectives and that you're able to answer these questions, and that will help you greatly focusing your study. So the first thing we want to think about is the child's experience being in the hospital, especially with something that's life-threatening or possibly going to end their life. So many times, especially now in the time of COVID, they're separated from the family. And so imagine how terrifying that would be for a child that's never been separated from their family. They experience a loss of self-control, autonomy, privacy. All of that is the same for adults, but then add to that experience, the child doesn't really know what's going on. That is really, really distressing. They're going to experience painful and invasive procedures. They're going to have fear of injury and possible disfigurement, and they are going to have their sleep patterns interrupted. So coping mechanisms for the child are going to depend greatly on the child's temperament. So usually a child's personality doesn't change enormously. So if they were previously pretty good at coping, they might be better at coping than a child that already had trouble coping. Some kids are going to experience more difficulty than other children with these kinds of issues. A lot has to do with their previous ability or memory of coping with something. So if they've been through anything difficult before, they generally bring that into their new experience. So if you have a child that's never been hurt or hospitalized before, it's going to be the most traumatic for them. Or suppose they had a terrible experience the last time they were hospitalized, it's going to be much harder for them. So many children will regress to prior behaviors, and we've talked about this before. Sometimes they will repress prior memories that they have had, or they may repress the whole experience of hospitalization depending on their age. They may not remember anything that happens in the hospital when they're older. So they may try to interfere with the treatment in the hospital, which is one of the things we worry about. They may try to pull out IV lines, pull out equipment. They may need to be restrained, which is going to be terrifying for a child if they're restrained and alone. Coping mechanisms, their behavioral response. It's defined as your behavioral response, especially when it doesn't meet the demand of the situation. So poor coping is when you're just not meeting the emotional or behavioral requirements of the situation. Children oftentimes mirror the parent's behavior. So if the parent is afraid, the child will be more afraid. So sometimes as pediatric nurses, we have to intervene to stop a situation where the parent is actually feeding the child's fearful behavior. And maybe pull them aside, talk to them out in the hall, and maybe suggest that they take a little time to go get some coffee or walk around so that they can come back and be strong for the child. Or maybe they can bring in additional family members that can help while they try to get themselves together. Common coping mechanisms especially with serious illness or injury, there'll be the whole 5 stages of grief. So denial, repression, regression, postponement, and bargaining is basically the 5 steps that they'll go through trying to cope. And that goes for the parents and the children. Nursing diagnosis. So communication may be impaired. If it's a young child, verbal communication may be impaired, or maybe they're on a ventilator that can impair their verbalization, or perhaps they're unconscious. So that would be a possible diagnosis. Spiritual distress related to the crisis of illness or suffering. So generally the parents will have more of a spiritual distress. They will think like, how could God let this happen to their child? Children, they may or may not suffer spiritual distress depending on how old they are, if they've internalized a spiritual way of thinking, or if they do have, were raised in a spiritual household. Their distress might be that they're afraid they're being punished by God. Sleep patterns are, you can almost put this down on every care plan you have. If you can't think of something, you can almost always put down disturbed sleep pattern related to the night shift at the hospital. Generally, children don't cope as well with that. Sometimes kids sleep straight through when the night shift nurses come in and they never even know, but especially if they have to be woken up, it's going to cause some behavioral issues, especially if they came in the middle of the night from the ER. That can be difficult. So nursing diagnoses continued. We have activity deficient. The activity is that the child would normally do to divert themselves away from whatever pain they were in. When you're in the hospital, it tends to be worse because of forced inactivity. So diversion is very important as far as pain relief for children. They respond to it almost better than anything else. Goals in this case, we're going to want the child to express any feelings of insecurity, and then that would be allowing them to vent that, and then try to help them feel secure. So the goal is to help the child get to where they feel secure again, get the child to where they feel as though they're in control again of the situation, increase the child's comfort. Okay, so interventions that you were going to do in order to do that. We're going to keep the family close and informed if we can. This is important. And we're going to, even more than with adults, the family's going to need to know what's going on all the time. And they may be beside themselves with grief. So we even try to provide them a special room so that they can go through this and not in front of the child. As far as the child goes, you want to provide the child with choices, of course, manage their pain. Children are chronically undertreated for pain, and that's really a tragedy when you think about it. Provide emotional support, so important. Sometimes children, when they're below a certain age, there's not much you can do because the parent is the only one that they can get emotional support from. But as children get older, and especially the family, the family is going to be almost more work than the child as far as providing the psychological and emotional support. The family in crisis, remember you're treating the whole family here, so not just the parents, but siblings, grandparents. You can consider, especially in a situation like this, that the whole family is your patient. So there's a threat. Part of the crisis comes from, prior coping prior problems the family have gone through, so their experience with coping. There might be a threat to the family stability, especially, obviously there's financial, but especially when it's potentially life-threatening, the whole family obviously is going to be disrupted by this situation. Generally a family member is going to have to, one of the parents usually is going to have to stay with that child. They may or may not be able to work. If there's other siblings, they may not be able to provide care for the other children, and there's an interruption of the parent's normal ability to parent the child because they're in this situation where everything's different. Early reactions to a traumatic situation will be grief, a lot of grief, basically because of the child. They experience a loss of what the child could have been. For example, suppose the child has a problem where maybe they're going to have a lifelong disability. They will grieve because they may have had hopes and dreams that this child would be a football player or a musician or a college graduate. So they're going to be grieving that loss. There's shock, disbelief, anger, guilt, deprivation, and loss. And I know that this is review because you've had grief and loss classes for adults. So I want you, even though this is review, to try to think about how it's going to be different with a child. Because when you have an adult who is declining, many times it's expected, but even if it's unexpected, they've lived their life. And so when it's a young child, especially, they haven't had a chance to live. And so the emotions are a lot more pronounced that you're going to see. Kind of a, I don't want to use the word dramatic, but just a lot more, a lot more expressions of emotions you're going to see. So anticipatory waiting is that feeling that parents have that they are always waiting for the doctor to come to hear if there's any good news. And so a lot of parents will say, it feels like I'm always waiting for something. We're waiting for an x-ray, we're waiting for the medication, we're waiting for the results of a test, we're waiting for the doctor to make. So they can tend to talk about that, how painful that process is of waiting for something. There's a readjustment period where they start to come to the realization that whatever's going on is going to be a new normal for them and the family. And like I brought up earlier, the mourning period. Nursing diagnoses continued. We talked about interruptive family process, spiritual distress, but also fatigue. So stress is very, very fatiguing to the family. If you've ever been under severe stress, it can feel like you start to sleep 16 hours a day because you just, it's a result generally of the overload of stress hormones, but also related to the sleep deprivation of being in the hospital constantly, of not going home and getting the amount of sleep that you need. So a lot of families are encouraged to room in with the children so that they can sleep. And it's not ideal because they're not going to get the kind of sleep that they would get at home, but it's better than not being able to sleep because they're separated from their child. And now with the COVID thing going on, this can be really terrible because I know they're limiting the amount of families that can go on the pediatric units right now. Hopelessness is another nursing diagnosis. A lot of parents feel that that there's no way that the child is going to get better, or especially if there's a serious condition going on, they see the child deteriorating, then that can be pretty terrible for them, especially if they lose hope. Hope is one of those things that as nurses we try to instill in families, but especially if we need them to have hope in order to try to get better. But there's some cases where we don't want to give false hope. False hope can be the worst thing. It can really undermine your relationship with the family if you give false hope. And there are some cases where the child, it really is going to die, and to give, families are going to experience hopelessness, and sometimes it's appropriate for a while. We don't want to undermine that grieving process because it can make it a much more long and pronounced grief afterwards. So some amount of grief and acknowledgement of a hopeless situation may be appropriate. Goals that we're going to be setting for the family is expressing feelings of reduced fear. But I don't see how, when you have a child that's dying, for example, this may not be realistic. All the way up until the child dies, the family may have difficulty having reduced fear. Parents demonstrate adjustment to death by making post-death plans, and so this is kind of a positive development when you see this in the family, because they're starting to think about life after the child dies. And that sounds morbid and terrible, but it's kind of healthy if they get there where they're able to do that. Interventions that we can do. So we want to provide as much information to the family, especially if the child's dying, about what the dying process looks like, as far as knowing that it's normal for a child to stop eating, or anybody that's dying really will stop eating at some point, and they may stop drinking. It's normal for them to start to shut down physically, emotionally. Encouraging visitations, referring to spiritual counselors as needed, involving the child in post-death body care when the child does pass. Those can be something that's really healing for them. Feelings of abandonment. So what we need to, siblings can experience this profoundly. When the other child is sick, they will feel abandoned by the parents sometimes. And also they can feel, even after the child dies, they can feel abandoned, especially as the parents are grieving and maybe going through a period where they can't move on. And in some cases, the grief can be so profound that families never move on, leaving the sibling kind of feeling permanently abandoned. So siblings will have behavioral changes. It's important to treat the sibling as just as important as the family in this situation, and take the time to spend with them as though that they really are your patient too. They will appreciate it because the parents may not think of it. Expected outcomes of nursing care are going to be that in this case, are going to be that the siblings are prepared to visit the child. So you don't want to just let a sibling walk into, suppose that one of the children has been in a car accident and they're on a ventilator, and maybe there's blood, maybe the child just looks really terrible. You don't want to let a sibling walk in and see that without some preparation. So we're going to do our best as nurses to try to prepare them for what they're going to see, and then provide emotional support and assistance to cope with that. Palliative care. Remember, palliative care means that we're providing anything that'll help relieve suffering and improve their quality of life, but it won't save them. So for example, say you have a cancer patient, palliative care could be providing pain control, anti-nausea medication, maybe even antidepressants. Sometimes when kids are dying, you'd be surprised, they'll put them on Valium and things of that nature to kind of help them cope. And so anything that gives them a better quality of life as they're going through the dying process. Sometimes there's overlap and there's ethical concerns about whether or not the care you're providing is curative or prolonging a life that may be very difficult. So, for example, with cancer care, the ethical decision process there could be, do we try more chemo? Do we try more life-saving or life-prolonging treatment when maybe every day that the child lives is painful and difficult? Maybe there's a time to give up, but this can be a really difficult decision for parents when it comes to making these kind of decisions. It's a lot more traumatic than it is making that decision for an elderly family member. It's one of the hardest things I've ever seen anybody go through. I don't think it can get worse than this. Hospice care, there's nurses that are specially trained on how to do this, and especially hospice nurses that specialize in pediatric hospice. That has got to be the most difficult job I've seen it, and takes a special person to be able to do it. But the focus is exclusively on comfort at this point, and giving the family choices about the kind of health care they want the child to get, so that the child can have a dignified and, I don't want to use the word rewarding, but the best possible interaction with the family as they're dying. Ethical issues also come into play with brain death criteria. So, for example, many times a child will be brain dead, and we judge that by their electrical activity on an ECG. So many times a child will be brain dead, but they'll be alive on a ventilator, and the family will have difficulty coming to grips with the fact that it's very rare and almost to the point of being non-existent that people recover from technical brain death where there's no electrical activity in the brain. And so, as a nurse, a lot of nurses feel ethical distress at keeping a child alive just so that the parents can have time to cope with the fact that the child's dying. Some families don't believe that it's right. It's their religious belief. They don't believe in withdrawing care. And that can be disturbing to the nurses and doctors involved because it feels like the child's suffering, and we're doing things that are basically prolonging their lives for no reason. Their suffering is the biggest problem. Other times, the family can be divided where one parent wants to let the child be withdrawn from care and the other one doesn't. And in that case, it can get really ugly, especially for the nurses involved who get pulled kind of in the middle. So just know that it's usually never the nurse's decision, and I wouldn't try to influence that decision really in any way, because I wouldn't want that responsibility personally. That's kind of where I stand on it. They should be making their own decisions, and I like to not be drawn into that conflict, but it can be difficult to be around as you're providing nursing care when this kind of conflict is going on. Sometimes there's legal considerations. We had a case where the child was with a father. The father, his story didn't make sense about how the child got injured. And so it was highly probable that the child died from shaken baby syndrome, but the father was telling a different story. And in the meantime, the child was brain dead. And the question was, the father obviously wanted the child to not be taken off life support because then his charges would have gone from child abuse to homicide. And he was recommended by his lawyer to fight that. And the mother wanted the child taken off life support because she was aware that the child's brain activity was was gone and didn't want the child to suffer. So they were in a deadlock until the father got arrested, and whenever one of the parents is arrested for that kind of thing, they kind of have their parental rights suspended, and so then she was able to withdraw the child from care. So nurses can become kind of overly caught up in this kind of drama that's happening around the child, and we do our best to stay out of it and try to stay non-emotional. I always say that it's not our job to really have an opinion. And we're all going to have opinions, but not to express them about what's going on there to the families. Do not resuscitate orders. This can be very difficult because it allows the healthcare provider to not provide chest compressions and mouth to mouth and all that. But any parent would say, why would you not do that? If you could save them, why would you not? But there's obviously, if in a case when a child is not going to get better, that can be less traumatic to the family, but they have to sign orders for that, and that can be a difficult thing for them to come to that realization. And especially, I've heard of incidents where a child had CPR done upwards of 20 times in one evening because the family wouldn't withdraw care. And so if you could imagine your whole entire night shift being giving chest compressions, that would be a very difficult night for you. And not that that's the point, the child is the point, but is that really doing the child any good? That's probably the bigger question. Awareness of dying by developmental age. So depending on how old the child is, they'll have a differing understanding or maybe no understanding at all that they're dying. Even if we don't tell the child that they're dying, older children will figure it out, but younger children may not. So the nurse wants you, as the nurse, you want to assess this psychological status, physiological status, the comfort level, and the child's knowledge about what's happening. We're obviously going to assess cardiovascular, respiratory, neurological, muscular, all of that. When I was in Guam, we had a baby that was born at like 20 weeks gestation, which they're not considered viable until 23 weeks, 23 to 24 weeks, I want to say. So the child was not viable, but they continued to breathe after they were born and have a heartbeat. And so they were still technically alive. And so the nurse, which was me at that time, my whole job was to take vital signs on the child until the child passed, and basically document the time when the heartbeat stopped, because there was nothing we could do. And so that took, I would say in this case, it took about 45 minutes, which was kind of hard to watch, but it can come to that where that's what you're doing. Nursing role in communication, so you want to be open with the family about what's going on, or possibly even the child, honest if you can. Once in a while you get a family that doesn't want the child to know that they're dying, but if that doesn't happen, being as honest as possible is good, but putting everything in language that the child can understand based on their age. Finding out what they know first before you go in and start talking, very important. And pay attention, what does this mean, death imagery? So sometimes children understand death by using certain imagery, like they'll say, oh, I had a dream last night that these evil demons were trying to kill me. And the nurse will realize that maybe that dream represents the child's understanding of their disease process, how it's trying to take them, or they could have imagery like they saw crows pecking at them, or they saw something. Just be aware that those kind of imageries that the child used can be ways that they demonstrate their understanding of what's going on. And then once they do that, a good thing to do as a nurse would be to try to encourage them to think of death in a more positive way. If they're dying, I would want them to think of that as in terms of if they're a religious family, maybe it's okay to talk about angels coming to get them instead of the negative. Or if they're not a religious family, try to talk about positive imagery about death as the circle of life, and that kind of thing. Support the family. Again, some families will want to donate the child's tissues and organs, so the child can't consent to that legally till they're 18, but the family can. But there's only you have to be certified to be able to talk to the family about that. So your job is not to talk to them about that. If they ask questions, you can tell them that you'll call the right people, but you don't want to start talking about that unsolicited. And then you also want to know if they're going to want an autopsy on the child. I would say 90% or so children that die don't get autopsies because we know why they're dying. But the main reason you would need an autopsy for a child is if abuse is suspected, if poisoning, or if there's an unknown reason, if we don't really know why the child died. But in very few cases do we not know why the child died. Here's some sample things from your book about communicating with the child about death and dying. So it says, what are you really worried about? So when the child brings up some kind of bad dream they had, this can be a way to get them to talk about their fears and worries and get them off the negative imagery. And that way the child can express how they're feeling. And it's a good thing to encourage the child to express themselves even if they're upset or angry. It's better out than in, as I like to put it that way, because when you harbor those feelings inside, they make you worse. Try to show empathy for the child's feelings. Reassure the child that you'll be available to listen. So you don't want to be too busy with this child. You want to always, even if you are busy, appear that you have plenty of time if they want to talk to you. Ask the child what's the most important thing for them to do with the time they have left. So sometimes when a child's dying, they have specialists that'll work with them, and one of the things they might do is have the child record a video for the family to watch when they're gone, or a picture book for the family to look at when they're gone. Sometimes they want to write a piece of poetry or do an artwork or something. So that kind of helps get them involved in doing something positive about children. They're young, but even young children can think about leaving a legacy behind. So we're going to try to help them find meaning through leaving some kind of legacy. So that involves getting the child involved in art, music, and writing to kind of help them leave something. Acknowledge the child's life can be complete even if it's short. So maybe the child, that's one of the things Make-A-Wish Foundation tries to do is, but wish fulfillment often doesn't make the child as happy as we'd want sometimes, but sometimes it's very important. One of the cute things I saw recently that the Make-A-Wish Foundation did was, it's not necessarily trips to Disneyland. The child wanted to experience Christmas one more time, and they were dying in the summer, so they weren't going to be able to make it to Christmas. So the foundation got together and talked to all the people that lived on the kids' block. And so all the families in the block got together and decorated their house for Christmas and put up Christmas lights and put up all their lawn ornaments, and I believe they even brought in fake snow, and the whole entire block got involved in this. And I think it made a huge difference for that child just watching the video. It's a real tearjerker. But it meant a lot to the child. And then, if possible, with children that are old enough, help them participate in treatment decisions. So it might be appropriate that a child be able to say whether they want to quit cancer treatment, for example. It depends on how they're doing cognitively. And we've talked about this in the past about their rational thought. So sometimes the child can make a decision that's different than the parents, and the hospital or the law will that they can get some support legally for that. Also, you've probably seen all this before, but you want to review this for tests on testing purposes, as far as what different beliefs are in different religions and cultures about death, and things that they might want to observe. And I like to always bring up the example of the Catholic family that I took care of, where I didn't know that the priest had to be there within an hour of death of the child, because it's not a belief that I am aware of, and I hadn't heard of it, that there was an hour limit. So you want to make yourself as aware of as possible of these kind of things, and certainly that would be a mistake I'd never make again, because I felt so terrible for the family when the priest couldn't baptize the child. I did find out later that many of the nurses I worked with are Catholics, and they could have actually done the baptism of the child before death or even shortly after death, and it would have been acceptable to the family. So now, you learn stuff, but hopefully you can know these things in advance if possible, so you don't have to learn it the hard way. So go ahead and review all these different beliefs. So caring for the dying child, there'll be post-mortem care, of course, and so you're going to want to talk to the family about what they want done. And obviously, if you talk to them, you won't have to worry about these kind of things. Follow the family's wishes, of course. Allow the family to have time with the child. It's common that parents don't think of the kind of things, especially if it's a sudden death. They don't think maybe they might like a lock of the child's hair. So the nurse can sometimes think of that and get a lock for the child. Mementos, so for example, the bracelet of the child, the hospital bracelet, can be important. If it's a baby, sometimes we try to save their onesie that they were in, the hospital type onesie, and send that home with them, because it's the last thing that the child wore or the last thing they saw the child in. And then also on pediatric units, a lot of times they have plaster of Paris, and they'll try to get a footprint or a handprint of the child, so that the family can go home with that handprint. It's very difficult for a family to leave. They went to the hospital with a child that was healthy, or maybe not so healthy, but they were still alive, and then they leave with nothing, and the child's just gone. So we try to make it so that they don't. Sometimes they make little necklaces for the siblings that the child maybe has their fingerprint in it, and so it's like a little what do you call that, a pendant that they can give to the other siblings or a few friends that has something to remember the child by. Things like that can really mean a lot. The parents will be grieving, of course. Siblings are going to be grieving. Sometimes the parents aren't supportive of the sibling at that moment because they're in extreme grief and suffering themselves. So it can be important to try to set the family up with maybe a counselor for the sibling that's surviving. Staff reactions. So I like to say that pediatrics is my favorite place to work because there's so little death. Compared to other floors, you really don't have to deal with the level of death. Most children are very healthy and resilient, and but when we do have a death on the floor, it's even more traumatic than it would be for maybe an older person because it's a child, because sometimes we project our own feelings of our own children into that situation, and it makes it worse because we can see our own child dying that way, or it just stirs up fear, or just human compassion for a dying child. It's very normal and human to have compassion for that situation and have it really get to you. So staff members oftentimes will need counseling for this, or sometimes, I would say the med room is a place where you'll see staff go in to cope, because you can cry in the med room or the break room with your friends, your coworkers, and they can support each other. That would be healthy. To see a person crying. It's more unhealthy when you see staff that's become indifferent to the deaths of, and this goes for any unit you work on. What you don't want to see is nurses and staff that's indifferent, because they just provide a lower level of empathy and care and comfort for families. So always be on the lookout for that, even in yourself. So staff reactions, you have to acknowledge the grief. If it's happening to a coworker, provide support, because as a nurse, your fellow coworkers are your patient also. So acknowledge their grief, allow them to cry, allow them to feel as though their feelings are acceptable. Don't try to poo-poo someone's feelings, or anger, or whatever they're going through in their difficult situation. Nurses need to share their grief with other people, and this is one of the hard things I've seen, because so many nurses have really difficult stories to tell, but nobody wants to hear them, and so they have nobody to tell. It's a lot like working at the VA, where you have these old soldiers and they want to tell you stories of their life experience, especially related to war and the military service, and they have so few people that want to hear their story. So if you ever have work with a nurse that wants to tell you a story, it's therapeutic for them. Let them tell you their story. That's one of the reasons I share so many stories, is besides the fact that I feel like it helps you guys learn, but it's therapeutic for me to know that I can share that story and maybe it can help somebody. So in summary, life-threatening illnesses or injury challenges the family's coping. It challenges the stability of the family. Divorce rate, it can be really high in families where a child is dying or having a serious illness, because the stress can be so bad that families fall apart. So as nurses, we want to try to acknowledge and help the family as best we can through these. The child's experiences are going to be different based on their developmental level, coping skills, previous experiences, and the supportiveness they have of their families. Nurses can provide appropriate direct care, clear communication, ongoing psychological and sociological and spiritual and all kinds of support. and just that nursing presence and empathy is the most important thing I think that we as nurses can provide. That's all I have to present on this. So I hope this format worked for you. Thank you.